Thank you, Kayla. Thank you, and thank you all. Good morning, good afternoon, good evening, and thank you for being here. For us, it's really a pleasure and an honor to have Carolina. We really appreciate that she has been part of the FMD community during all these years, and we are really happy to have her here. So I will just give a brief presentation on Carolina. Carolina Stenfeldt, DMB PhD, is a scientist working at the Foreign Animal Diseases Research Unit of the USDA in the Agricultural Research Service at Plum Island Animal Disease Center, New York. And also, this is done through a collaboration with the Kansas State University. She will go over a little bit on her education in Denmark, but it is important to highlight that her research has been focused on investigating FMDV pathogenesis, where she has provided really key parts of information about this really complicated aspect of the disease, and also in the transmission in different livestock species, with a special focus on the FMDV carrier state. So Carolina, once again, thank you very much. We are very happy to have you here, and the stage is yours. Thank you.
Thank you for that introduction. And thank you all who have tuned in today. The title of this seminar is Foot and Mouth Disease Virus Pathogenesis in Different Domestic Livestock Species. And I want to focus specifically on the aspects that are different between the common domestic hosts in relation to this disease, because I think that's something that's often a little bit overlooked. But I will start with just a little brief introduction of myself, even though Mariano did a very good job with it. I'm actually originally from Sweden, although most of my education comes from Denmark. I have a veterinary degree from Copenhagen, and I then went on to do a PhD working on FMDV pathogenesis in the group that was run by Graham Belsham at Lindholm, which was then part of the Technical University of Denmark. I had a brief stint working for the Swedish Board of Agriculture. That's basically the only part of my professional career that didn't focus on foot and mouth disease, but I was working primarily with anthrax. But since 2012, I have been part of the Foreign Animal Disease Research Unit at the Plum Island Animal Disease Center, working in the lab that is run by Dr. Jonathan Arzt. And in that group, I've focused almost entirely on studying foot and mouth disease virus pathogenesis and developing different experimental models for that. As of today, we're actually still at Plum Island, but within the near future, our unit will fully relocate to Manhattan, Kansas, where there's this nice brand new building waiting for us. It will not involve a daily boat ride, but we hope that we will eventually be able to adapt to that reality as well. So the topic is foot and mouth disease virus pathogenesis. I want to start out just briefly with some definitions and hopefully provide just a little bit of clarity of what pathogenesis actually entails and why I believe it's important that we study it. The main component of the presentation will be talking about how this plays out in our common livestock species, and especially as foot and mouth disease is again quite relevant, especially in Europe. I thought it would be important to include some material on differences in clinical presentations in these different host species, as well as differences in the actual pathogenesis and progression of infection. And then I will wrap it all up at the end, just talking a little bit about some recent research that has come out of our lab. I will strongly assume that anyone who found their way to this webinar is quite familiar with foot and mouth disease. So I'm going to bluntly just skip over this generic background slide of this being an RNA virus and a picornavirus and a notifiable disease and all that, because I think we're all quite familiar with that. So instead, I'll start with the statement that was quite common when I started working with foot and mouth disease. And there was this reference to foot and mouth disease, actually 7 different diseases. And with that, it was referring to the 7 different serotypes of the disease. However, the more we work with this, it's become clear that although there are clearly some differences in virulence and severity associated with different virus strains, the serotype designation in itself is rarely useful as a predictor of disease characteristics or transmission or severity, but instead the most prominent predictor for those things is actually the host that is infected. And there's a few examples of this. Different hosts, although susceptible to the virus, have different sites of initial infection, and this clearly affects the risk of the animal becoming infected via different types of exposures. Is also clearly relevant if you want to develop models to actually study infection. We know that foot-and-mouth disease virus causes persistent infection in some hosts, but not in others. But actually, even within the animals that are susceptible to persistent infection, the anatomic site of that virus persistent is different across hosts. So this chart is just a progression of any generic infectious disease. I think most of us would be familiar with this concept of the incubation phase, delineating the time from actual infection to the onset of visible clinical disease. There's also this more silent transition from the latent phase to the onset of infectiousness, which is the period during which the animal can actually transmit disease, and these may or may not line up with each other. But I'm going to use this as a background for the concepts that I will be focusing on more today. First, as already mentioned, the primary infection represents this very initial event through which the animal actually becomes infected. If we have the more conventional progression, there's also this phase of clinical disease, which is actually the disease as we know it. And if we're talking about foot-and-mouth disease virus, there's also this existence of this persistent phase of infection. Within these three concepts, primary infection is absolutely mandatory. If you don't have a primary infection, you don't have an infection, whereas the other two concepts are actually optional. And specifically, although we know that foot-and-mouth disease can be this very severe and scary condition, there's actually quite a lot of variability in the spectrum of clinical presentations. And there is this very important concept of fully subclinical, or what we call neoteric subclinical infection. Neoteric just basically refers to temporally acute subclinical infection, but it's different from the persistent infection specifically in terms of the amount of virus that is shed and thereby also the infectiousness. So with that, taking a short breath before going into the first of our concepts, which is primary FMDV infection. So primary infection is basically just a conceptualization of the very first thing that happens when an animal, in this case a cow, becomes infected, in this case with foot-and-mouth disease virus. So cattle are highly susceptible to FMDV infection via inhalation, and that also fits nicely with a confirmed site of primary infection in the nasopharynx, which is part of the upper respiratory tract. So it wouldn't really be my presentation if there weren't some basic anatomy reminders included. And on this drawing, the blue structures are part of the respiratory tract. Here that includes the nasal cavity, the nasopharynx, and the trachea. The nasopharynx is separated from the oropharynx, which on this drawing is in green, by the soft palate. And in this neutral breathing state, the caudal end of that soft palate is tucked in underneath the tip of the epiglottis, and that provides this free passage of air through the nares and the nasal cavity down to the trachea and subsequently to the lungs. Anyone who has ever done any upper airway endoscopy would be very familiar with this front-on view. If you stick your endoscope through the nose into the nasopharynx, you will look straightly at the larynx with the epiglottis at the bottom, and the lower boundary of the compartment you're in will be the dorsal surface of the soft palate. But what's important to remember here, that although we're used to looking at these like two-dimensional flat images, is that these structures are actually three-dimensional. So the upper respiratory tract is a tube in which these mucosal surfaces are actually continuous. But the nasopharynx is separate. It's a separate compartment from the oropharynx. The oropharynx is essentially a separate tube that is located below this soft palate. And I'll get back to why that is important a little bit later. This is a frozen and stained section of the bovine nasopharynx. This was obtained 24 hours after FMDV infection via contact exposure. The green color is cytokeratins. That's a marker of epithelial cells. That's your mucosal surface. The red color is the structural capsid protein of foot-and-mouth disease virus. So those are your infected cells. The light blue cells are CD11C stained cells, so those are host immune cells. So this is basically the cavalry coming in to try and keep up the defenses at the site of the initial intrusion by the virus. So moving on to pigs and primary FMDV infection in pigs, it has some similarities to cattle, but it also is quite different. Most remarkable is the concept that pigs are extremely resistant to FMDV infection via inhalation or even deposition of virus in the respiratory tract. Instead, we find susceptible tissues located in the upper gastrointestinal tract, specifically in the oropharynx. So now we're in that different compartment. We find primary infection here in epithelial crypts of the oropharyngeal tonsils, specifically the tonsil of the soft palate and the paraepiglottic tonsil. This section is from this paraepiglottic tonsil at 24 hours after infection. Similar concept as in cattle is that the primary infection is localized at epithelial cells. It's always reticular epithelial, like lymphoid-associated epithelial. But the difference here is that rather than being on the surface of the mucosa, we're in these epithelial crypts of the tonsils in the pigs. This is a similar section. It's from the tonsil of the soft palate. It's obtained at 48 hours after infection. So this is just at the very onset of the clinical phase of disease in pigs. And what we see here is an increased level of virus replication. The red cells here are just forming this microvesicle within this epithelial crypt. It's actually quite nice moment captured. And this gets even more dramatic as we move through this clinical phase of infection in pigs. And this concept is actually also different from cattle. So in cattle, we have primary infection at a different site. It's up in the nasopharyngeal mucosa. But there we have this maintained low-level virus replication in the primary site, simultaneous as there might be this systemic generalization and actually clinical disease. But at the primary site, the virus stays in this low level of replication, which can go on for extended time periods. In the pigs, this primary infection site instead turns into this hotspot of viral replication amplification and causes a lot of virus shedding into the environment, but is then subsequently completely cleared from that site. Moving on to sheep. Sheep are also ruminants. Similar to cattle, they are susceptible to FMDV infection via inhalation. We have evidence of primary infection happening in the upper respiratory tract, but there is a quick dissemination to also involve epithelial cells in the tonsil of the gastrointestinal tract, so the palatine tonsil and the paraepiglottic tonsil, very early on in infection, regardless of if you have a systemic dissemination of infection or not. So now that we've established primary infection in these different species, we want to look at what comes after that. So these slides, they clearly involve a little bit of simplification just for the sake of clarity. As I mentioned in the beginning, we're all familiar with foot-and-mouth as the severe and dramatic version. And for our domestic pigs, that is almost uniformly true. I didn't even include the option of subclinical infection for pigs on the slide. That clearly doesn't mean that it can't happen, but it's quite unusual. And pigs typically do develop, at least our domestic pigs, develop clinical signs of FMD once they're infected. Sheep, on the other hand, are somewhat notorious for their ability of subclinical foot-and-mouth disease. There is undeniably more variability in the clinical picture in sheep, but this common notion that sheep don't get sick of FMD is actually quite inaccurate, and I think might cause it to actually be missed because clinical foot-and-mouth disease can present a little bit differently in sheep and a little bit less dramatic than we're used to seeing it, specifically in pigs and cattle. But there are often signs of clinical disease, and I'll get into that a little bit later. It can be somewhat difficult to recognize if you don't know what you're looking for. In cattle, this neoteric subclinical infection that I mentioned before is very common in animals that are vaccinated or that have acquired immunity from previous virus exposure. It is also common in certain breeds of cattle and specific breeds that are common in areas endemic to FMD. They have some genetic resistance. They still get infected, but they don't develop the severe clinical FMD, and they might be completely subclinical. So after transitioning the clinical phase of infection, animals with either clear infection completely or not, a subset of infected ruminants, which doesn't include the pigs, will become what we refer to as FMDV carriers. So pigs, although very dramatic in their clinical presentation of FMD, are really good at clearing this virus. There's no persistent state of FMDV infection in pigs. Amongst the ruminants, this can go either way. Important here is that there's no association or correlation between the occurrence or severity of clinical FMD and subsequent occurrence of the FMDV carrier state. The carrier state is reported to occur in approximately 50% of animals, and clearly 50% is a nice round number that you get if you average somewhere between 0 and 100. So there's a lot of variability here, and it shouldn't be cited as an exact number, but it's also somewhat useful. We'll get back to FMDV persistence a little bit later on, but I thought I would move on to show some different varieties of clinical presentations first. So, as mentioned, clinical FMD exists on this continuum from quite mild to very severe disease. The very severe cases are often easy to recognize, specifically as large numbers of animals in a herd will be affected somewhat simultaneously. I should remind everyone, though, that FMD actually does require a laboratory diagnosis. It is a vesicular condition, but the vesicles rupture quite quickly and instead leave erosions. The early stages of vesicles look like somewhat you can see on the left image here, with this very characteristic white blanching epithelium around the lesion sites. Once the vesicles have ruptured, they're a little bit less characteristic. So if you look at the image on the right on that muzzle, that is foot and mouth disease, but it could probably more easily be confused with something else, such as maybe blue tongue. This slide shows some characteristic foot and mouth disease lesions of varying ages in pigs. Domestic pigs typically are quite severely affected, and they will be unwilling to stand up or walk around during the worst parts of the clinical disease. In most cases, they do recover, but you may have issues with chronic foot lesions or deformities that would clearly be very problematic in a production setting. Interesting finding from experimental studies that have been done in feral pigs or Eurasian wild boar is that although they do get similar lesions, these animals seem to be less affected overall, so they will be walking around and eating and maintaining more of a normal behavior despite having severe lesions. This slide shows FMD lesions in sheep. So as I said before, sheep actually do get foot and mouth disease, or a lot of them do. The most common signs are high fever and lameness, but lameness in sheep is quite common due to a variety of infectious diseases, which is, I think, why it might be easily overlooked. The images on the left here show these very characteristic foot and mouth disease lesions in the interdigital cleft of sheep. So again, you have this very white blanching epithelium forming vesicles. Those are quite easy to recognize if you see them, but I find that foot lesions in sheep are often just a little bit more subtle. They can look like what you have on the right-hand side here. That's also the foot of a sheep. You do have a vesicle. There's actually an accumulation of fluid here, but it's located just beneath the upper portion of the hoof wall. So it doesn't really look like our normal foot and mouth disease, but it's very painful. This sheep would not put any weight on that foot, and you can definitely feel it with your hand. It's different from the early lesions in cattle and pigs that you can see on the other pictures. Even those are very early vesicles too, but they're still located above the hoof. So, and you have this whitening of the epithelium that's very characteristic. With the sheep, I find it's sometimes even more subtle than what you can see. This picture, they will have fever and be lame, and you can feel an increased temperature in the hoofs, and you'll often have some like diffuse edema around the coronary bands, but you might not be able to find actual characteristic vesicles, at least not until a few days later. So cows are somewhat known for their dramatic mouth lesions and hypersalivation, which doesn't really happen that much in the other species. However, sometimes it's even a little bit more subtle in the cows. This girl just had these kind of cute little blisters on her nose, which is foot and mouth disease. Mouth lesions are often more difficult to recognize in the other hosts, specifically in pigs. Sheep do get these dental pad lesions, as you can see in the image, but they're often quite subtle and they disappear relatively quickly. Then there are also clearly more complicated or conflicting cases, at least out in the real world. This image is actually from one of our experimental animals, which turned out to have a pre-existing infection of bovine papular stomatitis, which is a parapox virus, which at least in the US is quite ubiquitous in young animals, and it has a tendency to flare up. We've seen it more than once in our experimental animals that are transported and acclimated in our facility, that it can flare up suddenly in a number of the animals. And this picture here is from a formalin-fixed piece of a dental pad of a different animal from the same cohort. And you can see that the characteristics of these lesions are quite different if you know what you're looking for. but it can clearly be confusing because they're in the same place. So I guess the message is, if you have an animal with slightly conflicting lesions or confusion, sample more than one site, preferably. So after transitioning from this clinical phase or complete lack of clinical disease, we arrive at what we like to refer as the transitional phase of infection. And so by mechanisms that we haven't quite elucidated yet, some percentage of ruminants would maintain this low level of foot and mouth disease virus replication through what is commonly referred to as the FMDV carrier state. We don't yet know the absolute full explanation behind this condition. It's likely related to the efficiency of the cellular immune response or lack thereof, and the Th1 versus the Th2 weighted host response. Animals that are carrier and those that have fully cleared infection will have a very strong antibody-mediated response, but this is, in some animals, not sufficient in actually clearing the infection fully. So this slide shows foot and mouth disease virus infection dynamics in cohorts of experimentally infected cattle. This is FMDV RNA detection in different sample types. So you have detection in serum in the red, as the red line. The green and blue are detection in nasal fluid and saliva, respectively. This blue shaded area is the clinical score. So that's the time during which the animals were actually sick and had lesions. But the important part of this these graphs and the difference between the top and the bottom is this purple line, and that is detection of foot and mouth disease virus in oropharyngeal fluid or probank samples. And I'll get back to the technology behind that in a few slides. But the important part here is the difference between the carriers and the non-carriers, and that's this maintained presence of FMDV in oropharyngeal fluid in roughly 50% of animals past the mysterious, somewhat random, but widely accepted threshold of 28 days. Although in our studies, we've actually shown that animals that clear infection typically do so quite a bit earlier. I was considering showing similar graphs derived from other host species. But apart from this lack of FMDV persistence in pigs, those graphs would look essentially similar. Short version is, if you have an animal that is sick with foot and mouth disease, you will find the virus in essentially any sample that you collect. We don't recommend using serum because the viremia can be quite transient, especially in milder cases of the disease. However, if you have an animal that doesn't have clinical signs of FMD, but that you suspect might be infected, then the only efficient way of detecting virus would be to collect oropharyngeal fluid samples using a probank cup. These graphs are similar data, but now we're looking at vaccinated cattle. So these animals were completely protected against clinical disease. They also did not have viremia. But again, you have this similar concept with this divergence between animals that completely clear the virus. We can see this quite a bit earlier than 28 days here. And then we have this cohort of persistently infected carriers that have this continuous presence of FMDV in these oropharyngeal fluid or probank samples. This is a section of bovine nasopharyngeal mucosa. This one was harvested 35 days after contact exposure. We have these few FMDV positive cells in the surface epithelium. Again, the epithelium is in green, that's your mucosal surface. The careful eye might know some differences compared to the acute phase of infection, is that during the persistent infection, we don't really have any erosions or structural disruptions to the mucosa. There's no real signs of inflammation or otherwise activation of the host response, but we have this low level of virus replication. This virus is not latent, it's actively replicating, but at this very sort of sluggish level, it continues to stay around in these epithelial tissues. So back to the brief reminders from anatomy class again. The nasopharynx is part of the upper respiratory tract. So the key element here is the soft palate, which in the neutral position here maintains free passage of air through the respiratory tract. However, anyone who's been involved in collecting probank samples would be quite aware of the fact that the probank cup is actually inserted through the mouth of the animal, not the nose. But there's quite convenient mechanism that opens up the separation between the oropharynx and the nasopharynx, and that's our common swallowing reflex. During which the soft palate is actually lifted out of its resting position to physiologically provide access for feed to passage from the mouth and the oropharynx into the opening of the esophagus, which for some reason is located above the trachea. But so to collect a probank sample from a cow, the tool is inserted through the mouth until you feel a swallowing reflex or a complete lack of resistance. And this should bring you to the approximate level of the larynx, where you can gently scrape the mucosal surface and hopefully catch some of those infected cells that we were looking at the previous slide. If you're used to collecting probank samples, you're probably also very familiar with this concept that sometimes when you're pulling back on your probank cup, you'll feel this very firm resistance. And that is essentially your probank cup getting stuck on this caudal edge of the soft palate, which closes back to its neutral position again. And it'll take a little bit of wiggling and patience to get your cup and your sample back out again. Right. So sheep are not little cows. And when I was a vet student, we were told that God created species differences to make sure that life wasn't too simple for veterinary students. And that definitely applies to FMDV pathogenesis too. And sorry, my light's going off. Persistent FMDV infection in sheep is not located in the nasopharynx, but instead it's localized to epithelial crypts of the oropharyngeal tonsils. Should be some continuity in these concepts. So if you want to collect probank samples from a sheep in order to detect persistent FMDV infection, you're better off specifically targeting this region rather than using the same technique as commonly used in cows. So in the case of sheep, you want to not go too far in with the probank cup, but I find it somewhat helpful to measure the external distance to the eye and then target that approximate distance. Also note that the tool that we use for the sample collection in small ruminants is different from cattle, and that's because the regular cow probank will very easily get stuck and cause injuries in the sheep. So aim to scrape the dorsolateral oropharynx without getting swallowed. If you go too deep and your tool gets swallowed, it will not destroy your sample, but your sheep will be very upset, and it can be quite hard to get the probank back out again, and also you'll have less consistent detection. This is an ovine section from an ovine palatine tonsil that was collected at 28 days after infection. Important again to emphasize, this is different from cows. FMDV does not persist in the tonsils of cows, it does in sheep. This section looks a little bit similar to what we looked at during early infection in pigs, which is because it's the same actual anatomic site. We don't have this massive replication going on. This is persistent infection, so the virus is sort of sluggishly replicating along in these epithelial crypts, but it's in tonsil crypts, not nasopharyngeal mucosa, because this is a sheep. So what about pigs? We did quite an extensive study to basically confirm previous knowledge that pigs do not get persistently infected with foot and mouth disease. This section here is the popliteal lymph node. That's a lymph node that drains the foot. The red color that you can see in the center of this lymph node is structural foot and mouth disease virus antigen. Very important here, though, is that there was no infectious virus present in these tissues. We tried very hard to isolate infectious FMDV from a lot of tissues from a lot of pigs, and we did not succeed. This here is captured structural antigen. It's part of how the immune system presents antigen to maintain this antibody-mediated immune response. These antigen will also disappear within about 2 to 3 months after infection, and there is no actual persistence of infectious FMDV at all in pigs. So I want to spend the last part of this presentation talking about some recent research that we have done in our lab studying foot and mouth disease virus superinfection and recombination in cattle. So we've known about this concept of foot and mouth disease virus recombination for quite some time, and specifically this knowledge has evolved as whole genome sequencing has become more available. So the evolutionary history of virus strains can look quite different depending on which coding region you're looking at, and this has been concluded by multiple groups studying field samples from different settings. So it's evident that recombination happens between different strains and serotypes of FMDV out in the real world. But what hasn't been quite clear, though, is how these recombinants have come to be. So through the past few years, 5 or 6 years or so, we've done quite a few experimental studies that were specifically designed to try and answer some of these questions. The slide is just to illustrate some of the iterations of animal experiments that we conducted. The most common assumption by ourselves and others before we started this work was that if FMDV recombination was to occur, it would most likely happen within vesicular lesion, because that's where we have this very high level of virus replication. But since we'd also done a lot of work on FMDV persistence previously, and we had some interest in immunity potentially conferred by heterologous infections, we wanted to also see what would happen if we took an FMDV carrier and then superinfected it with a completely different strain of foot-and-mouth disease virus. So to summarize a lot of work on one single slide, we found absolutely no evidence at all of FMDV recombination in animals that were simultaneously infected with 2 heterologous viruses. These animals were infected by both viruses. They had lesions caused by both viruses, mostly as single virus vesicles. We did have some vesicle samples with multiple viruses, but it's a little bit hard to say if that was actually separate vesicles that had coalesced as they developed. But regardless, there was absolutely no evidence of recombination happening in any vesicular lesions. But in the scenarios where we separated these virus exposures by 3 to 5 weeks, so we had carriers, and then we exposed them to a different virus 3 or 5 weeks later, we did find interserotypic recombinants as the dominant virus in sequential, so multiple oropharyngeal fluid samples, in about 50 to 75% of the animals. So most of these, or at least half of these superinfected animals, remained subclinical. So initially we thought we had failed. We exposed them to a second virus and nothing happened. But interestingly, when we analyzed the samples from these animals, we could see that they were actually, all of them were infected, and all of them eventually cleared all viruses except one. There was no real pattern, but they would be co-infected with multiple viruses, and as time went on, all viruses except one, it could be either one of the parental strains or the recombinant strain that would persist. But we could detect these recombinant viruses from nasopharyngeal tissues as early as 24 hours post-superinfection, which means that these recombinants are present very early on. And if you recall, I was talking about this neoteric phase of infection, where subclinical animals are actually shedding more virus than the carriers are doing. So that's very relevant here, that the recombinants would be present during that phase of infection. This is just a schematic illustration of some alignments of some of these recombinant viruses. Initially, we saw this common pattern of the entire capsid coding region being derived from the most recent virus. So our hypothesis at first was that the lack of antibodies against the superinfecting virus would give that virus some selective advantages. So the capsids of those viruses would be part of these recombinants, whereas the non-structural coding regions were part of the initial virus. However, when we reversed the order of these virus exposures, things got a little bit more complicated, and we got more variations in these more complex mosaicisms. So virus that we recovered had evidence of multiple recombination events, and some of those viruses had even regained the capsid coding region from the original virus, to which they absolutely had antibodies already. So that was interesting. I'm not going to talk more about the specific details of this study. It was quite recently published in the Journal of Virology. So if you're interested in that, I recommend go looking at that paper for the methodology and such. I will instead move on to talking about why I think this is relevant. So this thing about persistent infection is that they tend to hang around for some time. So specifically in endemic countries where culling of animals is not commonly used to control FMD outbreaks, these carriers will remain in the population. These areas also often have co-circulation of multiple variants of foot-and-mouth disease virus. So there's quite a high likelihood that an animal that is persistently infected with FMDV will eventually be exposed to a different version of the virus. So we remind ourselves about the FMDV progression in cattle. We have this primary infection in the nasopharynx, which can then cause the systemic generalized infection or not. We can have this fully subclinical neoteric infection, and then the virus persists again in the nasopharynx. So basically, we can have this sort of circular situation where an animal that has one FMDV virus in the nasopharyngeal mucosa get exposed to another virus, and again gets this primary infection on top of the persistent infection, which may or may not give rise to these recombinant viruses. And specifically in endemic regions where there's often some pre-existing immunity, many of these animals will remain subclinical, but potentially shedding considerable amounts of virus into the environment. So from a more epidemiological perspective, the slide is basically showing the same thing. If you have an outbreak with one virus, a subset of carriers will remain in that population. And then if a second virus comes along, you may or may not even notice that you have clinical FMD in the herd, but these carriers can become super infected. And then you have this possible situation where you have a rising generation of recombinant viruses that could be further disseminated from there. We do actually have a little bit of evidence of this actually happening out in the real world. This slide shows a publication from 2018. The original study was based on serial sampling of herds of dairy buffalo in Pakistan, showing introduction and circulation of multiple variants of Foot-Mathesis virus in these multiple herds without any reports of clinical FMD. These animals were all vaccinated and probably exposed multiple times. The original work was based on VP1 sequencing, but we've been fortunate enough to be able to go back and get full-length sequence from some of these viruses. And sure enough, when we plaque isolate and sequence these viruses, we see similar patterns of recombination as we did from our experimental studies, but in this case involving viruses that were also detected on neighboring farms. So what's about Foot-Mathesis virus recombination in sheep? We thought that was a good question, and specifically, as sheep are small ruminants, they're also susceptible to persistent FMDV infection. I should maybe admit that I have a little bit of a fondness for small ruminants myself, so I was quite keen on doing this work. But based on the work that we've done in cattle, it seemed like a natural progression to move forward and look for similar occurrences and patterns in sheep. However, sheep are not little cows, as we mentioned before, and we did quite a lot of work, multiple experiments with quite a lot of sheep and at least 4 different viruses. And so far, we have not found a single recombinant Foot-Mathesis virus from any sample from any sheep. So sheep are different. Hypothetically, this could possibly be a direct consequence of the anatomic site of persistent FMDV infection not being similar to cattle, and specifically not being similar as the site of initial infection in sheep. So you have a slightly different situation there. And those details matter, apparently. But to sum up the important concepts here, cattle are highly susceptible to FMDV infection via inhalation or exposure of the respiratory tract. We have both primary and persistent FMDV infection at the very same sites, the reticular or lymphoid-associated epithelium of the nasopharyngeal mucosa. The clinical presentation is often uniform within cohorts, even though I mentioned there can be quite a bit of variation, specifically associated with cattle breeds that are common in FMD endemic regions. So we have this occurrence of subclinical neoteric infection in both vaccinated animals or previously exposed animals, or animals that just have a genetic resistance to the clinical manifestations of Foot-Mathesis. Regardless of the occurrence of clinical disease, there's a high prevalence of virus persistence in the nasopharynx, and we see frequent virus recombination when these carriers get superinfected with the different variants of Foot-Mathesis virus. Sheep are different. They do get Foot-Mathesis, a very important part. There is more within cohort variation in clinical signs and severity. We very often see fever, high fever, like 41 degrees Celsius, and lameness. The vesicles can be difficult to identify, and they won't be uniform within the cohort. Often you will have increased temperature of the hoofs and edema of the coronary bands, and then some of the animals will develop these interdigital cleft vesicles that I showed images of that are a little bit more characteristic and easily to identify. They are sensitive to infection by inhalation. Persistent infection is localized to the oropharyngeal tonsil crypts, which is totally different from cattle. And possibly because of this, we see absolutely no evidence of FMDV recombination when we superinfect persistently infected sheep. However, FMDV can persist for months to years in sheep, but the epidemiological contributions of sheep is less well studied. However, there was this quite substantial FMD outbreak in the UK in 2001, in which sheep had a very important role of disseminating the outbreak because they were transported to markets across the country. I found it very interesting going back and reading this publication, because there's this minor detail that this group of 10 sheep or whatever that they follow were actually treated for lameness before they were sent to market. And it doesn't describe why or the cause of this lameness, but I think it's an interesting point. And so maybe there were actual clinical signs of FMD in these sheep before they were sent to market, but no one was expecting it and they didn't know what to look for. So short version, in these times where FMD might be knocking on our doors again, is that lame sheep should probably get a little bit more attention than what is generally common practice. Pigs are really, really resistant to FMDV exposure of the upper respiratory tract. They are susceptible to oral exposure. It does require a higher virus dose compared to the other guys. We have found primary infection in the epithelial crypts of the oropharyngeal tonsils. FMD is often quite dramatic in pigs, and because they get quite dramatically sick, they're also really good at transmitting it amongst themselves. Once one pig gets sick, it spreads really quickly within groups. However, since they're not really susceptible to inhalation of virus, they need to be actually in physical contact with each other for efficient transmission to occur. Very importantly, there is absolutely no persistence of FMDV in pigs, and don't get fooled by finding some structural antigen in lymph node. That is not the same thing as persistent infection. So finally, I want to thank all the people that have contributed to this work. As I mentioned in the beginning, all of this work was done in the lab that is run by Dr. Jonathan Arzt. Ian Fish is our evolutionary biologist. He's done all the work with the sequence and the sequence analysis from these superinfection experiments, so very important. And clearly also a lot of other members of the Foreign Animal Disease Research Unit have contributed to this work. And I myself is hired through a collaboration with Kansas State University, who also have contributed overall to this work. So thank you very much for listening. And I think we have time for questions.
Thank you, Carolina. It's really remarkable how during all these years many observations that were common were somehow explained, but all these numerous manuscripts and work that you have done together with Jonathan and his group. So I think that's really a really relevant collaboration to understanding FMD. So I was going to ask you to highlight the relevance of your work, but I believe that you have already done that during your presentation. I don't know if you want to add something else to that or any comment.
Yeah, but I think part of it, and I think I felt this a lot when I started working with FMD, that there's a lot of like preconceived knowledge that people know things, and I think sometimes you should question what you know, and specifically when it comes to these, just be aware that there are differences both in clinical presentation and across host species. So even if we know a lot about this disease, there are these subtleties and we don't know everything. So just be a little bit open to the variability.
Yeah, no, of course. Yeah, that's right. Okay, I will start with one question from myself, and then we have some questions from the audience. Question about the vaccines. In your experience, are there any conventional vaccines at current that may work better than others in preventing or reducing the occurrence of carriers? Would it be dependent on the potency of the vaccine? Would it be dependent on how homologous are the infecting and the vaccinal strains? None of them.
There is work from other groups that have shown that high potency vaccines are better at preventing persistence. We've tried it and we haven't had that effect. We've also tried some vaccines that prevented persistence in one experimental model, and then we used a different experimental model and it didn't. And I think important part there is when you're doing vaccine challenge, the most common way of challenging the animals with the virus is to inject it in the tongue. And I think that is entirely appropriate. It's the most stringent way you can challenge your vaccinated animals. But the thing is, if you have homologous good vaccine protection, your virus isn't going to get any further than the tongue, and you're not exposing the upper respiratory tract. So it's really not a good model to assess persistence, because if your vaccine induces a strong enough protection, then your virus has no chance of persisting, because it's not going to persist in the tongue. So if you use a contact challenge model or a different model with the same vaccine, you may still have complete clinical protection, but because you're exposing the upper respiratory tract, you might actually get subclinical infection and persistence. So it's just, I'm not saying don't do tongue challenge, keep doing tongue inoculation, but don't use those models to conclude whether or not your vaccine prevents against persistent infection. That would be a subsequent study.
Right. Yeah. Okay, I will start with the questions from the audience. Fabrice Banduseco. He says, according to some field surveys, farmers or breeders said that SAT2, the SAT2 serotypes, causes more damage than other serotypes. Can lab trials with serotypes from Africa show any difference from what you have been finding so far?
It's an interesting question. I haven't done work with SAT2 myself, so I'm maybe not the right person to answer. I have heard, this might be unofficial information though, but experiments that were done with some African SAT2 viruses that were subclinical in the field, but then they took them to the lab and did tongue inoculation, and the animals actually got sick. So again, the experimental model might be important there, and maybe also the breed of the animals. I think I don't have a really good answer, but it's something that would be relevant to look at. But it would be important to control for things such as how do you expose the animals to the virus? Because if you do tongue inoculation, you're entirely bypassing any mucosal defenses and the entire respiratory tract. So your clinical outcome will likely be different from what you see in the field when animals are actually exposed by breathing in the virus. So it would be interesting work to do, and I think someone should do it.
Sure. Great, thank you. Benedicto says, thank you for the very informative presentation. You mentioned that in cattle and sheep, some animals become FMD virus carriers after infection, while others do not. Could you elaborate on whether host viral or environmental factors are primarily responsible for determining this carrier status? Additionally, for how long can sheep remain carriers of FMD virus, and what are the possible reasons why pigs typically do not become carriers?
It's a really good question. So this is essentially what I've been working at, for most of my career, and I don't have answers to all these questions. We believe it is mostly related to the host response to infection. We have looked at differences in virus, with sequencing the virus, looked for mutations, and there are some signals, but they're typically not consistent across experiments or serotypes. Also, the thing of host response, it fits with the reason that pigs don't become infected, because we infect the pigs with the same viruses that cause persistent infection in other species. Our hypothesis currently is that it's related to this Th1 versus Th2 response. So if you have a strong Th2 response, you have a stronger antibody-mediated response, which has probably had some evolutionary advantage in that the animals need to clear the viremia, because that's what's making them sick. But the persistent infection is usually completely subclinical, and the animals are fine. So there's no real fitness disadvantage to the host to have this infection, as far as we know. But these are speculations. We think it's related to the host response. We have some data on it. It's not fully elucidated. Pigs typically have this more dramatic clinical disease, which might also stimulate a different host response. But yes, it's a very interesting subject to study.
And about the length of the persistence. Benedicto is asking about the lamb, but this can be extended to other species, because this has been a kind of a fuzzy issue.
It is, and it's hard to study. And there's this quote of 5 years for cattle, but when you start looking for the actual evidence, it's like one cow in one scenario, and we probably have it closer to 2 to 5 years in cows under natural conditions. But sheep are reported to have both a lower prevalence and a shorter duration. I haven't done that work myself, so I don't know, but I think 6 months to a year is more commonly quoted for sheep. I don't know how many numbers of animals that's based on, but it's clearly hard to do that work because you need to keep the animals around for quite some time.
Right. Okay, we are adding up a lot of questions, so we'll try to go as fast as we can. Okay, Amara Leno, thank you so much for your presentation. My question is, how can you support country that can collect sample for the shipment and testing since the capacity is not in the country?
Yeah, I think that's
yeah.
I mean, that's a really good question regarding FMD control, and I think certain organizations, specifically EU FMD, have better resources for that. So I recommend looking out for those resources. The other thing is to collaborate with labs in countries with more resources. But clearly, it's a big problem and a big issue that should be addressed.
Efren Foglia says, I have a couple of questions regarding the cell populations involved in the entry and persistence of a virus across different species. When comparing FMDV susceptible cells in the 3 species, are there similar cell types distributed in different tissues, perhaps sharing common physical or molecular characteristics, or do they appear unrelated? Are the cells involved in viral entry the same as those involved in persistence? I can also add to that, if have you find any relation between the proximity of the FMDV infected epithelial cells and the host immune cells in the outcome of persistence?
Yeah, so this is interesting too. So we have these, if we start with the primary initial infection, it's in different locations in the different hosts, but the cells look very similar. It's always epithelium, and it's always epithelium that is closely associated with lymphoid tissue. So this fenestrated reticular epithelium or lymphoid-associated epithelium. And it's the same type of cells, we believe. It's hard to prove that it's the exact same cells, but it's the same type of epithelium that has both the initial site primary infection and the persistent infection, regardless of the different anatomic location of this epithelium. So you can find this type of epithelium both in the nasopharynx, so the dorsal surface of the soft palate, or the dorsal nasopharynx, and also in these epithelial crypts of the tonsils. You can also find this type of epithelium in many other places. There's a pharyngeal tonsil, nasopharyngeal tonsil, that I didn't even mention because we collected in all of our animals and we've never found Foot-and-mouth virus in it. So it's not enough to be a tonsil, you need to be the right tonsil. So there clearly are other factors involved that are restricting. We don't really know. It's not as simple as the occurrence of a simple receptor. But I think that mostly answered it right. Yes, it's the same type of cells. Both across the species and across the different phases of primary and persistent infection. During the clinical infection, you have infection in a wide variety of just cornified epithelium on non-head skin, which is a different type of cells.
Yeah. Okay. Chrysostom says, great work. I am curious to know, it's moving now. Okay, I am curious to know if the investigation of persistent and superinfection consider the impact of previous vaccination.
We didn't do that in these studies, mostly because it's hard for us to get access to vaccines for our experimental studies. For some reason, companies don't want to sell us vaccines. So we haven't done it in vaccination, but we did see that in a lot of the superinfected animals, they were actually protected from clinical disease by the previous infection. So they got infected, but they didn't get clinically sick. So in a way, that would be a similar situation as if you had a vaccinated animal, but clearly it would be interesting. It would be interesting to do the co-infection studies in vaccinated animals because it would probably be a better representation of what's actually happening out in endemic countries.
Right. And have you characterize the virulence of recombinant virus that arise from the superinfection experiment?
No, and I think it's something that we probably wouldn't be able to do because of gain of function concerns. So we haven't done that. We haven't seen any evidence of these recombinants being any more virulent or have better fitness than the parental viruses. And as I think I mentioned too, the animals typically clear all but one virus. So they can have both parental virus and a recombinant on one time point, and then at later time points, they will keep one of those viruses around, but there doesn't seem to be any clear preference for either parental or recombinant. So it seems mostly stochastic, but it would be interesting work to do.
Okay, well, I think we have time for 2 or 3 more questions. Mohammed Abou-Sena says, could pig infect cows by direct contact or by aerosol infection? Why would we conduct challenge tests in cattle by intradermal lingual inoculation, and we didn't use nasal drops infections, while the cattle are more susceptible to infection by the nasopharyngeal route? Yeah.
That's a really good question. And I think that's part of one of these conventional truths, like we infect animals by injecting the virus because that's the way our predecessors did it, and that's how we do it. I think there's a place for the tongue inoculation in vaccine evaluation because it is a more stringent challenge. So if you want to evaluate a vaccine, I think you should do tongue inoculation. However, the way we infect most of our animals is we insert a flexible plastic catheter through the nasal cavity into the nasopharynx, and we deposit inoculum there. We have also done what you're mentioning, infecting pigs and putting them in the same room as the cows. Most of the microscopy images I showed were actually from that study. And most of the reason we did that was to confirm that our nasopharyngeal deposition of virus isn't causing any bias or anything different. So we've done contact infection. Pigs are very useful for that because they shed a lot of virus. The cows don't need to be in direct physical contact with the pigs. You can just have them in the same room because they're breathing out enough virus to actually infect the cows. But clearly these are more involved studies and you'll have a bit more potential for variation. Yeah. So it depends on what you're investigating, but you really, I mean, I guess the part is you need to design the study that fits with what you're actually wanting to prove. If you're studying pathogenesis, then tongue inoculation is not very useful.
Yeah, pigs are very effective in infecting. The problem sometimes is that you don't know the viral load that they are producing.
Yeah, no, and even the time of infection can vary.
Okay, Amara Lino, she's asking about, well, actually she's presenting a problem in Sierra Leone about the suspected cases of FMD, and she's asking support with the vaccine. I can tell Amara that she can contact us at the GFRA, and we can talk with her and see what is the situation and how can we help in developing some studies and support for her. Finally, Denison Quisito, thanks for the presentation. Have you found any viral determinants for subclinical neoteric FMD infection?
No, short version, very short answer. We haven't found any difference in the virus. We think this is mostly related to the host and the host pre-existing immunity, but also this thing about certain cattle breeds are just less susceptible to clinical FMD.
Yeah. Okay, the last one. So Naxon Babi says, which serotype may be more likely to cause severe illness in cattle, sheep, or pigs?
Yeah, that's a question without a good answer. And as I mentioned in the beginning, the serotypes are really not useful determinants because there's so much variation within the serotype. So you can have 2 strains from different serotypes that have very similar virulence and very similar pathogenesis, whereas 2 strains from the same serotype might be highly different. So overall, no real answer to that. The virus strains are different, but the serotype should maybe exclude some of the SATs here, but typically the serotype is not a good determinant for virulence or host specificity.
Right. Okay. I think we are reaching the end. I don't know, Kayla, if it's already 1 hour. Is it?
So we are, in fact, at the top of the hour. So I think we're going to wrap up here. But thank you so much to everyone for joining. I do just want to note that as you leave the webinar, you will see a quick survey pop up. I ask that you just take a minute or two to fill that out. We really do rely on the answers to those surveys to keep this webinar series going and to continue improving it all the time. Thank you so much to Dr. Stenfeldt for joining us today and for your incredible presentation. And thank you, Mariana, for helping to moderate this webinar.
Okay.
Thank you.
Thank you, Carolina. Thank you, Kayla. Thank you again, Carolina, for this excellent presentation. Thank you.
Thank you.
See you soon.